To finish the surgery, both pectorals will be centered together as well as the scapula.
I think we modified, now it's modified. The screws are different, same level. You don't need to drill, they're a little longer. The screws on the plates are different longer. And we change the incision. The horizontal incision is okay, but vertical midline incision is better. Only problem is when you push it around and take out the bar is sometimes difficult. What we modified the edges of the rib plates, you just have to bend a little bit so that they stay. Because what happens when it comes up, the rib plate can press your ribs down, and that can cause a problem of looking aesthetically well or not. So you put it down, then it gives you a bit more lift to it. I will show you this. This is our video, which was done through one of our medical students to the iPhone, which is not very good quality. But you can guess what we see. This is the pushing it inside, and it's quite brutal, but it's very easy. You don't need a scope, skin to skin 1 hour, you can easily do this one. And it goes in a plate, and then we put a market, you take out again, and put a plates on it. We put wires on 2 sides, like as we say, the belt and braces. And now the plate comes up. And then we put bar wires around just to prevent any issues. It's a good operation. My resistor loves it because less work for him. Every mass you have to lift up. And I do a 20, 30 plus. It's a hard work. We sweat at that operation. Okay. So this is the kit. What is changed now is the screws on this one. Around here, and they're much longer washes, and there's a screw on this one, which are all same, 5 screws. And then these screws are longer, and the plate are a bit more bend. The screwdriver is much better imported. It tells you how much to give a torque and not breaking the osseous bone of a sternum. The CT scan is essential before you get this thing. These are some of our patients, what we did. This is how we do the measurements. These are some of the operations. If you do older than 30, 40, if it's calcific costal cartilages, then you have to do little incision and take out those cartilages before you do the practice up. This is just showing off our patients. And these are some images of our operation. So in a short, comparatively, it's very selective, good. Practice of negative features cost 2-3 times. You've got to be very specific in patients. Start with people who have a low Harlow index because you get the best results. Then start with higher Harlow index, and then you start with tilt. Tilts are difficult to level out. But I think they're getting cheaper. NAS pain is nowhere near the NAS pain. And Practice doesn't clear up the rib flare. We have a device for rib flare along with the operation. It's coming. Its port cap is done. The CE mark is taking time, so you can use it, but that's coming. So there you go. The practice up, no video script, so that less expense. You can do it just by yourself. You don't even need assistance. Just need a good screwdriver and knowledge of orthopedics. You guys are all done ribs. It's just a similar extension of that. So there you go. I told you about everything which I know. And thank you for inviting me today. And I think we could go from strength to strength, and I think we should. I've been trying since 2011, and recently they picked up. We did advertorial, I did at Times, online articles, we did a whole promotions, but somehow we couldn't find patients. And now we have. Thank you.
Rajkamal Vishnu. He is from Chennai and has significant work on pectus patients. So he was talking around on pectus carinatum and back in therapy, and also his experience. I have been trained in Thailand regarding pectus work. Over to you, Raj.
Yeah. So good evening, Manoj. Thank you for this opportunity. Thank you, Shyam sir, to making it very simplified because you had explained most of the stuff. So I'll just get into the topic directly. So the pectus carinatum. So it is less commonly seen than excavatum, and as in a combination also we see excavatum and carinatum together, mixed kind of deformities. So there are many classifications of carinatums and excavatums. Each surgeon has their own. So to make it very simplified for newly performing surgeons, we keep it as a simple carinatum and a complex carinatum. So simple carinatum, we can just see a straightforward protrusion, and the rest of the symmetry is still maintained. So next is the complex carinatum. So we can see a huge carinatum on one side and excavatum on the other side, and it can be a mixed sort of deformity. And sometimes a rib flare is also associated with the carinatum kind of stuff. So principle of carinatum correction. So previously Jakub sir has done it. So that is about press molding to evenly remodel the chest wall, external pressure to compress the carinatal portion, internal support to prevent the surrounding areas from being excavated, and eventually the entire anterior chest wall included in the repair. So basically it is called a sandwich. So press mold sandwich is like an external bar on the subcutaneous level, and there is a chest wall deformity, and below the sternum we place the internal bar. So surgical technique is minimal invasive repair of pectus carinatum. So symmetric pectus carinatum. So we need to focus on where the focal point of protrusion is. So we need to address that part initially. So we need to place a subcutaneous thing and then internal. So overall corrections will be this one. So why the subcutaneous bars won't be visible in this sandwich kind of technique is, so we are getting sandwich between the internal and the external bar. So there is a compression is very much more severe than the simple placement of just a subcutaneous bar. In an asymmetrical type, we need to align accordingly where the protrusion is being formed. And in concave or convex and complex procedures, so the external bar has to be molded accordingly. See, in this one, there is a concavity on the right side and there is a convexity on the left side. So we need to bend the bar like convex on the right side and concave on the, or normal on the, we should do more of correction on the left side for this patient. So we'll be seeing that. So I take full credit from Dr. Park in this video to present this. So this is a sandwich. This is a complex carinatum repair. So we need to focus on which part of the carinatum is being protruded out, or which part. So surgical planning on table is crucial. So this is a CT film of the patient with the carinatum. So carinatum, as such, you don't require a crane lifting because there is enough space already to pass it. So initial marking is very, very crucial. So at the same thing, we have to compress and see whether it is depressing, how much of depression is possible with manual compression. So when you place the bar, it will be more compression will be adequate. So this is a marking of the subcutaneous tunnel. So first we pass the subcutaneous tunnel. So initially there was a pericostal sutures were taken to the intercostal space, and then again it was subcutaneously taken to fix the rib. Now it is not required these days. So same side, so 50% of the tunneling from one side and 50% from the other side. So once this is passed, then we can just pass the chest tube into the forceps and then railroad it towards the other side, and then the pectus bar is placed. If there is no support internally, then definitely we can see the pectus bar from the subcutaneous thing. So once you pass the internal bar, then the subcutaneous plane, you won't be seeing any of the bars. And this is the crucial step in for carinator. This is the compression technique. Without the compression technique, this procedure cannot be completed. So once you give enough compression, you are making it remodeling or preconditioning the chest wall accordingly. And through that, then the wires which were passed were fixed to the ribs. Along with compression, so we can see hardly we are not seeing any of the subcutaneous bars placed. So this is the placement of internal bars. So we can see the focal protrusion over small parts over here. So we pass the internal bar. So we will be molding accordingly. So intercostal space is open through that same incision, and we'll be passing a pectus scope. Through the scope, we'll be navigating through the other side, and same like a mass procedure, we'll be passing the bar and flipping it. So once we flip it, the residual focal protuberance or excavator is being corrected, and we fix it by the bridge stabilization through the screws and plates. So once the correction is done, this is the results, end results of it. And if required, you can place a small drain or subpectoral even analgesic, this one also can be kept. This is a post-repair and the pre-repair. So this is a pre-repaired CT. And this is a post-repair. In this one, this is important. This, straightening of the chest wall is very important, so that we can see the actual correction has been done. So this is another procedure for complex carinator, where we can see a focal, very large protrusion, and other side also there is a excavator, and there is a focal protrusion on the costal flaring is also there. So we do same sandwich method. The sandwich method can be different. Previously we had seen one bar outside and one bar inside. For this we can mix and match. We can place 2 bars outside or 2 bars inside. It depends upon the correction. They say eager not face, but I say it's Mount Kailash kind of thing. So same thing. So first we pass the internal bars to correct the excavator part of focal protuberance or excavator, anything is there. So we pass the pectus scope inside. So main area of concentration is this part, and the other areas of focal excavator parts are marked previously, and through this one we are passing a straight bar for excavator correction first. So once that is done, then we pass on to the other part, so where we pass into the subcutaneous tunnel. So through a pectoscope, we pass the another internal bar. This time it is an X configuration for the internal bars. Now we want to place the external bar for compression of the carinator part. So once these internal bars are placed, we need to fix this bar first before placing the external bar for this kind of surgery, for complex carinatum, because to stabilize, because we need to compress more on the carinatum part. And we pass the stabilization bar. So with this one, it will be a rock solid stabilization. So whatever compression you give on the top, so nothing will affect the movement of the internal bars or any disruption of the intercostal muscles. So once this is fixed, now this is the most important part, like preconditioning, okay? Because the chest wall was never used to this kind of compression from the external bars before. So we need to compress the sternum for 5 to 10 minutes for that, and after that we pass the external bars. So we mark which place exactly we need to pass the external bar placement, and we do the subcutaneous tunnel like a previous case. So once the bars are being placed, you need to compress it completely accordingly to how much ever the correction is required. Once that is done, then you pull the external bar close to the stabilization bar. Then you fix it with the screws. All these steps look so complicated, but the procedure is so simple with all these gadgets. And we fix it on both the sides with this simple stabilization and the screw. So sometimes if the bars are not able to come, you can just pull the bar along with the sternal wire as well. So you need to fix the most carinated part on the one side. That side of the bar has to be fixed first, and then on the other side. The normal side has to be fixed the later part. So once that is done, these are the results of total correction. So we are not seeing any of the bars placement subcutaneously. We are not able. It's not so visible in this case also. So both the cases we are not able to see because of the effective compression of the bars externally and then fixing with the stabilizer very deep behind. So morning also we had seen one girl with carinatum. So we can do the same procedure if she is around more than 10 years old. Yeah, definitely we can perform this kind of case. So parallel bar sandwich technique. So two internal bars and one external bar with a bridge fixation. These are the other options, multiple options we can do. This is a X bar configuration, one bar externally. So this is a sandwich technique where patient had a flare also, where we had to do 2 internal bars and 2 external bars and with a bridge stabilization. So we had the concept of entire chest remodeling rather than just lifting up one part of the pectus deformity. So basically we divide into multiple zones. So this is the area we need to completely focus, because one area when we live, there is some kind of misalignment or malalignment on the other sides of the chest wall. So that needs to be addressed as well. So that's why entire chest wall remodeling is essential. So usually there is upper zone, middle zone and lower zone. So when you place a single bar, you just correct that zone alone, lower zone alone. And when you place 2 bars, you are correcting middle zone and the lower zone. Upper part is left. But when you change the bars into cross configuration, the surface area is more and you can correct middle zone and lower zone together. And with the placement of an additional bar if required, you can just correct the entire chest wall. So the goals has to be regain normal anatomy, maintain functional integrity, restore human dignity and quality of repair. This is the high-end pectus surgery. And definitely for pectus excavator repair, the crane lifting method holds very good, because once you lift the sternum up, you have the space is there, and then you can contour the shape accordingly which suits the patient. And then once surgery is done, then you fix with the stabilization. Already the stabilization holds the rib cage together. Then you release the crane, the sternum sits on top, it doesn't exert any force on the plates, and there is no disruption of the intercostal muscle disruption won't be there, and there is very hard bar displacement options also. And this can be done with simple sternal wiring or screws can be done. So multiple bar approach for entire chest wall remodeling. We saw a parallel bar, a cross bar or an XI bar. So these can be done with stabilizations, bridge connections. So this forms a rock solid fortress where displacements are almost absolute zero. So this was Professor Sparks' theory, but 1919 to 2015, previously he has been using stabilizers, and there was a bar dislocation rates were high. And then slowly he switched to claw fixator, even that had a 0.3% of dislocation. Then he switched to bridge stabilization, where almost there was no dislocation. And since 2013 to 2022, there is 0% bar displacement by bridge stabilization. So always a multiple bar technique is always holds good, and with a bridge stabilization. So usual complications are pneumothorax, wound infection, sometimes pleural effusion, and reoperations like infection and hemorrhage. Those are the times when bar has to be removed. And the major complication wise with the stabilization, the cardiac injury was 0, bar displacement and procedure failure was almost nothing. So differences of neopectus surgery, like conventionalness, so power source is the pectus bar. So we directly place the bar, so that is the power source for it. But in a neopectus, the crane machine helps in lifting it all the machine, and the bar doesn't have the stress on that. Then shaping, morphologically tailored shaping, because we are concentrating on chest wall remodeling. So stabilization by bridge fortress and coverage, entire chest wall. Yes, carinatum we do by sandwich technique, where conventional thing cannot be done. So this is about carinatum. So I'll show you a short about vacuum belts. Sir has already very well explained about vacuum belts. So I'll just show some pictures regarding this one. So vacuum belts, as I said, it is for excavator procedures. Okay. So excavator, there are many sizes available for vacuum belts, and many sizes and shapes are available for vacuum belts. So So this is what exactly happens. See, this is a patient with excavator. Not coming? Yeah, sorry. So these are many shapes and sizes available in vacuum bells available. So it's usually for pectus excavator. So you see the defect here, the symmetrical pectus excavator, and when the bar is used, they have done a CT along with it. So we can see a good raise in that of the pectus excavator. So that means that it is very effective. Either with a vacuum, either skin has to be lifted or the sternum has to be lifted. Sternum will lift only if it is malleable, or younger age groups it is easier, and older age groups it's definitely not possible. So this is how it's been placed in the center, and so some people can use it as a crane lifting. They can use it vacuum bell to lift the sternum to create the space. That is also possible. Few surgeons has already done that. So vacuum bell is placed and a regular suction, they are just connected, and we can see there is a lift up of the sternum. Yeah, this was before the vacuum. This is before the vacuum, and once the vacuum is placed, yeah. So there is a space for that, and you can pass the tunneler, and then we can do the surgeries. So how do we measure it? So it's internipple distance and then the anterior chest wall. So you have to measure accordingly, and adequate size is also very important. The smaller the size, the area won't be covered adequately. The larger the size, then it will be very cumbersome for the patient to wear it. So adequate size is very, very important. These are some few correction deformities. So whom to choose and which patients to choose is purely based on the surgeon and the availability. So simple corrections are definitely we can use the vacuum bells. And for female patients, we have a different shape to protect the breast as well. So all these are fancy items, but we definitely will come with some kind of complication, and one of the complication is the skin excoriation, the skin getting inflamed and this one. And this is a result with continuous wearing. So within 2 months and 3 months of the result, some people will have a very good results with the vacuum bell. But it comes with a cost. So some people will have blister formation because it is continuous friction. Sometimes the friction can cause a reaction to that. So alternate to that is some people they use protective device like made up of tattoo covering plasters or something like that. But it has to be changed every time. So it becomes a cumbersome again and then expensive also for that. So that is about brief about vacuum bells. Thank you.
So Raj, I have a few queries.
Yes, sir.
So you show all in the X configuration.
Yes, sir.
Would you go, so you already have one bar there. So you're inserting a second bar cross configuration. So you will go under that, right?
Under that, you will go under that because see that X configuration, it is not just, it has to be in the center of the sternum. If the pectus excavatum is on the lateral side, you focus that X exactly that X pointing more towards the excavatum part. So it lives more further.
Okay. You show all the underbridge within legs.
Yes.
And you have a single stair.
Single.
Yeah.
Yes, sir.
So how do you determine which point is curved?
Which
Point is curved. Like you have a number of stabilizers.
Yeah.
Why did you screw each one? I mean,
See what happens is,
center.
so when you place the external bar like this, so you compress it. That's why the crane compression is very much required. So you compress it. So when this bar reaches the stabilization at which point, wherever it reaches and levels with the internal bar point, you can screw anywhere. That's why we place the longest stabilization bar.
Okay.
So you can screw it any place.
Okay. So they have external compression. So it's absolutely mandatory.
Mandatory.
So you have two bars inside.
Yes.
And then you can pressing externally.
Yes.
Okay. So there won't be any compression on the heart.
Nothing, because we have already stabilized it below. When you place the internal bars first, you stabilize with the stabilizers, so that it is just below the sternum and it is stabilized on both the sides and it doesn't move downwards and it doesn't disturb the intercostal spaces also. So you can safely compress it.
Can you put the external bar and then compress?
Yes, compress. Okay. If you are putting a crossbar technique, if it is a single bar and a simple procedure, either you can choose superficial bar first or the internal bar first.
Shan sir, you will say is something about a banana stem. Can you elaborate on
I think
So because what happens is sternum shape, if you look from a sagittal way, if it looks like a regular sized banana, that means the tip is down. And when you put a bar, regular parallel bar, when you want to go at the lower part of it, often after correction the tip slips and the repair looks same, no matter you put 2 bars or 1 bar or 2 bars. I think it is a predicament. So between group of, we got a European sort of a working group on chest wall. So we felt that you put a crossbar. What happens is crossbar holds that tip high up and doesn't slip because it's from both sides. So that's the one I usually put crossbars in the younger people, and that worked. So it's a unique solution. Otherwise, you may have to do osteotomy and elevate that part. But crossbar has suddenly, I think this was an idea from the nurses replacement in the King's Daughters Hospital, and then Mustafa popularized it, and now we are doing it, and it works. But you have to have a correct selection. You can't plan it, but you need to be prepared to do it. I use 2 stabilizers on above, and I don't put stabilizer below. Some people put sort of stabilize everywhere. But lower stabilizer, because the rib cage, it obviously you see it. So that's why it's better to do that way. But it's a good technique. I think I don't have image, but if you take a cross section and then you draw, it looks like a banana sternum. Thank you.
Manju? Any times?
Only thing is, with so many rods going inside, I'm a little confused which one should come above and which one should come below. Whether the external one, like in the sandwich technique. So the external one has to come above? Or
See, sandwich is mainly for carinatum.
no, the fixation at the entry point.
See, when you are putting 2 bars inside, if it is a complex, you think you need more support inside, you are putting it 2 bars inside. Then you fix the internal bar first. Because whatever bars you place, the stabilizer is going to be single stabilizer. So you can fix n number of plates to the same stabilizer. So there is no issues with no confusion also.
So, do you feel the stability of the bars are better when you have bridge than when you have a stabilizer? Because the bridge is screwing the bar under the stabilizer. spacer is just being inserted in. So for more complex configurations where I can an external interns animation that it seems a bit more complex.
It's complex actually.
Yeah, so will it have a learning curve for the
Definitely not, sir.
complex or can I try to
You can directly start it off because so today we had performed a surgery. So we use the stabilizers for that. So the same thing we'll be using a bridge technique. So we'll be screwing it, and nothing is fixed to the ribs. Ribs are independent of stabilization. So it is a system-based, support. It is not related to the rib support or the sternal support. It is completely independent support. So you're giving a shape and contour to that, which is fixed on itself. So there is, it gives more stability. That is the main reason.
So when you do such complex constructions, there you maintain the bar from more than 3 years or it's the same?
The rule is still the same. So still we want the adequate correction. So less than 15 years, 2 to 2.5 years, more than 15 years, definitely 3 years. So that is a goal. So when we use a stabilizer, what happens is sometimes if the bars are thicker, so as we used, when the bar is thick, so what happens is there can be an intercostal disruption. So that is the main reason for the bar to slip in. So that's why we use a longer bar so that it goes at least in the mid-axillary line, till the mid-axillary line. So it stays at least, it doesn't slip in and fall. So that is the only thing with the stabilizer. So when we, Dr. Park used hinge, so same like stabilizer. So he had a displacement rate of 0.3%. So that's why it has been shifted to stabilization part. So see, when a patient comes for the surgery, they want only two things. One thing is the correction should be perfect, and at the same time there should not be any complication. And the main complication for us is displacement, bar displacement, because not only that we are going to remove the bar or counsel the patients, so we need to, that is a more dreaded complication for a surgeon in a pector surgery.
And how easy is it to remove have 3 bars sitting there?
Yes, all these are all titanium, so first of all, titanium, and still we have with the steel also, stainless steel also is there. So screw removal part is very easy because it's directly in front of you, so we can remove that. That plates alone will form some kind of crust at the edge, so that part has to be very, very careful. So as sir said, only a consultant who has done the surgery has to remove the plates to avoid the complication, direct complication. So, and when you remove that also, so we have to make it straighter on one part, and you have to go along the curvature of the thing, and it's better under visualization, always under visualization. That is the only thing.
So will you have the patient on the edge of the operating table? Because if you have to follow the curve, you have to draw the bar below the operating table. You have to bring it down.
Not necessary, sir. No.
I think in some cases,
Some,
what happens is
longer bars
for
maybe.
the Parks bar, they are a bit different. For the our procedure, you straighten either side, but when you want to pull it, then you just have to follow the curve. Sometimes it's so much so you have to sit on the floor to pull it out, because as you know, there's a crust formation, there's a little things. As long as you stay in it, you're fine. You go away from it, you get intercostal artery bleed and things like
Yeah, that is the only problem.
so, but never, ever flip it. You won't be able to do it. If you do it, you need someone strong like Balu there to flip it. But otherwise, don't flip it. Just follow the curve.
Yeah.
And straighten it because it makes life easier.
Easier.
And then you have to cut those wires which you put on today, and then you take stabilizer from one end, and then you can put it on other end without taking out the stabilizer.
Yeah. And in OT notes also we should properly mention like how many wires we used. Absolutely. Yeah.
So, any other questions? If you don't, yeah.
Thank you. I'm Dr. Tawzeed. Actually, I'm from Bangladesh. Thank you, my friend Dr. Lungi, for inviting me here. Thank you very much. Yeah, I have seen a very good presentation from Shyam sir and also my friend Dr. Raj. So it is the new procedure is not on done in Bangladesh. So I have learned a lot. But there are a lot of techniques both of you shown, the Shyam sir and Raj. They are very good. I have learned a lot. But I have some questions regarding the post-operative period. I mean, in the literature and other things, I have learned that most of the problem in post-operative period is pain. I would like to know about your experiences regarding the managing post-operative pain. And do you have any experience of having the bar out due to pain?
Yeah. So pain tolerance. See, first initial period, the pain is post-operative pain. That literal pain will be there, and later on, what they complain is, it is not the pain actually, it is the discomfort, like someone is hugging you tightly. That is the feeling they have. So that perception differs from patient to patient and the tolerance level. So it varies from patient to patient. So some will tolerate really well and some might literally little difficult for them to. And with the pain having removed, now we have many modalities of analgesia, and the cryo especially, it's very good. It lasts for 6 months actually. So once you do the cryo on both the sides, the pain will, almost like it was 6 months it will last. Yeah, so that is the thing. And we use directly like serratus anterior block on both the sides. Rather than epidural, serratus anterior block along with the intercostal blocks will be giving it. Those things.
So you prefer a status block for every patient?
Yeah. It is easier, we can find, either you can do or your anesthetist can do prior surgery or after surgery also. You can do.
The last two cases what we have done here, we have given thoracic epidural. Thoracic epidural based at thoracic 3.5.
No, pain free, no. So this guy is meaning he's comfortable. Previous one, he shifted to the room. So 3 days continued thoracic epidural infusion suggested, so pain free. Use
So,
post-operative analgesics.
Yeah, analgesics.
First 3 days, epidural gave us really good outcomes because they're completely pain free and the feel maybe after a couple of minutes.
And one more thing is, placing a longer bars can cause really a problem. See, longer bars, as it crosses more than mid-axillary line, then it will be a real troublesome for them because it goes very close to the ribs and it can start. That can also be there. And Shyam sir can also explain some of the
I
things.
think best is to, best is to use the cryo. Cryo has revolutionized the pain thing. So much so, all the adults, we don't use under 16 because the cryo company says that it's not tested on it. If you do 2 up to 4 interspace, don't go beyond second, above second, and between 3rd to 5th space, if you do it cryo, you do it from inside with a scope. You're a VATS thoracic surgeon. For you, it's easy. But you use a port where you put a cryo. I use cryo ice because we get it free, because we do so much cardiac surgery. And I use cryo ice for AF ablation, so I'm easy with it. But otherwise, you get EVM company, BVM company makes it. They're very nice, this thing, but they can only use from inside into space. But you get a small needles, you have a good anesthetist like him, then use it in pre-op, this thing, put it on 3-4 spaces under local, cryo it. When they come back, your pain won't be an issue. You don't even need epidural. It's a little expense, but it's worth doing it. The more and more you do, patients will tell you how hellish the first 2 weeks were. Thank you.
And India, actually, the proper intercostal nerve cryolysis is not there. It's very difficult to get. So we can use our pulmonologist help, where they use the cryoprobe. The same thing also can be used in intercostal space also, because their temperature is also -60. So that also can be done with. So that is another option for us.
learning curve that is involved in these cases. And how do you suggest
that we start the practice in this case?
I think, I think, say one thing is you need to have enough cases because you have 3 cases and you finish and don't have patients. So best is to start a clinic, see more and more patients, and then you do it. Because I'm telling you, when I teach around across the places, if you got 2-3 cases, the third case becomes very easy for you to do it. But to get a confidence and shaping and things, it takes around a year before you're, at least from my experience. And it helps if you're a cardiothoracic. If you're pure thoracic, that heart, dreaded heart, scares you off every time. Initially start with Heller index of 3.53 and the smaller ones. Once you get brave things, then you can do. But my advice, if you're doing a deep 10, 20 Heller index, use the crane because it's a simple. I don't like crane because I like a challenge. I have not yet done the transcardiac route. One day I'll do it, then I'll have to see the car. But it's a challenge. Important thing is you dissect the tip. If it's deep touching your chest wall, you will never go transcardiac. No matter what happens, scope goes, scope flat. As long as you keep feeling tips, you saw I was putting it. As long as you feel that, you know there is nothing in between that tip and the things. Otherwise, buy the Park scope. It's a dissector come.
Yeah, that is wonderful.
It's very pricey. It's got only one use for Park. Park's a whole hospital just does this operation. So he's a legend. Not everyone can do that way. We get patients across the world. So it's good. But I think if you use a 5 millimeter 30 degree, it's a good scope. You are thoracic, so you know what it is, and it's good luck. But never ever, if you see a pericardium in front, don't go. Pericardium has to be below your dissector. Then you're fine. The day you go through transcardiac route, then you will find very difficult to start again. But don't give up. It's the worst anatomy. Put a stitch on it, put a mayo wire, and still do a mass procedure. That shows you resilience. But it's important. Touch wood. 16 years, not yet transcardiac route. So you've got to be doing all your cases. You do it. Always take a senior help. Do it yourself. Never ever is a training case.
Yeah. No, it's okay. Thank you, sir. Thank you so much for the opportunity. Yeah, thank you.
So I think we had two fantastic lectures. I don't think there's anything more to discuss as far as practice is concerned. I'd like to take the opportunity to welcome our chief guest for the evening, Dr. Pawan Gorakanti. He needs no introduction. He is an inspiring director who is behind every new initiative here, and I'd like to thank him for his continuous support. I'd like to invite Anju to hand over a bouquet to Dr. Pawan. Thank you so much, sir, for all the support. I'd like to invite Dr. Vijay Kumar to give you bouquets to our two faculty. I'd like to invite Dr. Shyam, our international faculty, to receive a bouquet from Dr. Vijay Kumar. And I'd also like Raj Kumar Vishnu to accept the bouquet from Dr. Vijay Kumar. Thank you so much for accepting the invitation. I'd like to invite Dr. Vijay Kumar to say a few words and
So very good evening. So welcome to our chief guest, Dr. Pawan sir. I think special thanks to Dr. Bala and Dr. Manjunath taken up for next level of our thoracic department for the going to the subspecialty deformity correction of pectus deformity live workshop and today's CME. I think both the speakers they delivered a very good lecture. We are going online for all the upcoming and practicing thoracic surgeons. Thanks to all the faculty and participants. And mainly especially just I will tell brief about our thoracic department. 5 years back, the hospital, we are looking for the next level departments in the pulmonary field. Our visionary and dynamic and young director, Dr. Pawan sir, I think is visionary. We are added thoracic surgeon in the first time in our, I think, Yashoda group of hospitals. Dr. Bala is recruited with the vision of Dr. Pawan sir. So after this, we are seeing the COVID pandemic situation, how the pulmonary department, the visualized in the world and how the patients are suffering with even pulmonary problems. We are looking forward and extended the next facility of thoracic surgery followed by lung transplant program. So we started the program in 5 years back. Now we are one of the best center in the country. The thoracic department added with lung transplant program. So all these things, because our director is experienced and seen the world of Western and he was studied in the United States and practiced for 10 years in the United States, came back from because of our chairman and our MD's request. He came back to India and giving this opportunity to our Indians and giving whatever it is hospital developed not only for the simple emergency cases and this trauma and allied all broad and super speciality, but nobody is looking for furthermore like Western countries like transplants. So he taken a challenge and initially is having a problem with the board for convincing the many meetings. He is instrumentally and putting his foot down and recruiting the transplant department staff and as well as focusing the next level whatever required for whatever it is seen in the Western world that should be perpetrated through our Yashoda group to the public. Thanks to Dr. Pawan sir, your visionary. Today we are seeing and several thoracic surgeons in India and most of our pulmonary people also, and pulmonary department is one of the best department in India because of your visionary and the hats off to our director's vision and thanks to the Yashoda organization taking to the next level for each and every department. That's why today we are in a multi-organ transplant, one of the best center in India. We are working in this roof. We proudly say that where the employees, 10,000 employees are working in this 4 hospital. Within 30 years of period, we have treated lakhs of people and the last COVID pandemic time also, the 50,000 plus patients and we are the first only one hospital, private side, inviting and admitting and treating critical patients from the COVID and we did the second or maybe first transplant from the COVID patient also. We are running simultaneously 25 ECMOs and across the India 109 airlifts in the COVID pandemic and the same legacy is continuing and last month we performed 10 ECMOs. I think this is the best number and one of the good number in the country hospitals. So because of the great persons where it is thinking in the next level, these kind of things will be happening. The Yashoda group now it is competing the world, whatever the Western world, the equipment, the consultant, the quality of the people, the patient care, everything we are not less than any country because of this visionary
directors, maybe the future is taking it to the next levels to our group, and we are expanding our group to the other major cities of the country also. Thanks to Pawan sir once again, and a very big apology to Pawan sir. Now I am inviting our chief guest Dr. Pawan sir and our thoracic surgeon Dr. Bala and Dr. Manjunath and our delegates Dr. Sham sir and Dr. Vishnu. Please come onto the dais for lamp lighting program. Dr. Logia, Dr. Vini. Yeah. After that, Pawan sir will tell. Dr. Gopi Krishna, Sridhar, and Dr. Vikram, please come onto the dais.
Come, Hiral. Come here. Yes, come.
So now I'd like to invite our chief guest, Dr. Pawan sir, to say a few words to all of us. Thanks. Clinic. Okay, sure. Thanks, Dr. Bala. Thanks, Manju, and all the leading distinguished faculty from all over the world and the country. Thank you. At 9 o'clock in the night, I was not thinking maybe is it a movie or IPL match or something, but everybody is so keen, nobody is sleeping or anything, not even close, and I think that speaks for the quality of the topic and the quality of people we have here. So thank you all for attending, and this is like midweek too, right? Midweek, 9 o'clock. It needs a lot of effort to be here, but I'm sure you'll go home much more enriched because I think I'll come back to Vijay here said very many things for me. I will not take so much of credit, but we do have a great team, no? Like everything, like including the admin and top class doctors and all, because infrastructure is only one thing. It's like quality of service is what differentiates us, and I think you put in like unlike other hospitals, only in one city we have 4 hospitals, but all are big. Everybody is very surprised when they first come about Yashoda. Many people don't even know, but after coming in here, they are very surprised by the number of people we see in the ER, or like everything like 600 PTCS per month is, or 15 to 20 liver transplants per month. ECMOs also has like almost every week, even non-COVID time now also. Yes, last month we have 10 in Secunderabad itself, and other units also we have quite a few ECMOs and all these things running. I feel good though. Healthcare-wise, we are first world in India, at least top corporate, particularly because we focus on the bigger and best. I think healthcare-wise we are good, and that's great. I think we'll do it this kind of way. People automatically do come. Previously, I think from outside state and all, very few came, but during COVID, suddenly we had like 25 ECMOs simultaneously, including half of them were without a ventilator, like awake ECMO. All this was kind of new for everybody, but everybody coped up well. Even the first wave of COVID, when everybody was scared, we had 200 patients on ventilator. Rest of the city had only 50 people on ventilator, and each of these things. So we did not be, as long as we focus on the good work, I think people will come automatically is what is our belief, and we'll continue doing that. We'll, even if we expand, we'll do it in a different kind of, and not just blindly for the sake of expansion, but only after if we are able to provide quality services only. So that's great. So anyhow, I'll not take too much of your time. After telling about 9 o'clock and all, I'm taking, so somebody was joking like how stupid I can be in Hawaii. I'm exceeding my own top timings. So that's what I don't want to do. But this is like a really unique topic though. Like PECTUS and all is great for all of you, because it's in India, like maybe there are patients suffering from this, definitely there are a lot of patients suffering from PECTUS and all, but it's a little under-recognized. Same like lung transplant, not that there are not enough patients in India, but like till about 5 years ago, if you total number of Indian patients getting lung transplant was in single digits or less, I think, but now it's pretty well established. I think because of the great work you're doing, and similarly, I think other things like rib fixations and other high-end thoracic work. Previously, I think everybody was doing everything cardiothoracic, doing other works, surgeons or combinations. So, but I think it's good that it's specializing. Dr. Bala himself did cardiothoracic surgery and left everything and now concentrating only on thoracic. I think very, very few people do that, and so Manju is a latest generation, I think, thoracic with international experience in Austria, and also I think we have a great team here, but thoracic is the future, I think. Nowadays, cardiothoracic has become more like, I don't know if I can say this, so support service for cardiology kind of, but no, I think as long as only thing left is transplants and all, I think, but thoracic wise, there are a lot of, because lung cancer and all, previously incidence was much less. I mean, even the tuberculosis, lung cancer, I think it will keep increasing in the future. Even if smoking decreases also, some kind of adenocancer or some kind of thing will be there. So thoracic is in a good field, like transplants are there, and like PECTUS and all, we are like done, like pulmonologists, they can do some intervention.